Hello and welcome to Introduction to Pharmacology. My name is Dr. Bill Diehl-Jones. I'm a professor in the Faculty of Health Disciplines at Athabasca University. In this relatively short video, we will be discussing special populations in pharmacotherapeutics. We'll begin with pregnancy. And it's important to appreciate that pregnancy has an impact on all processes involved in pharmacokinetics, including absorption, distribution, metabolism, and elimination. And there are a couple of points to remember. One is that there is generally increased renal blood flow and increased hepatic metabolism. And there's also decreased bowel tone and motility, so that has an impact on absorption. The risk is always of placental drug transfer, and drugs which are non-ionized and have a molecular weight of less than 500 Daltons, which is to say most drugs, do indeed cross the placenta. Some, like heparin and insulin, do not appreciably cross the placenta. The other consideration is that some drugs are teratogens, and teratogens are substances which cause birth defects. The effects of a particular drug in terms of its teratogenicity really varies according to the stage of pregnancy. So it's not always difficult to assess. And the FDA does provide pregnancy risk categories. There are a few proven human teratogens, including thalidomide, most anti-neoplastic drugs, androgens and progestins, stilbestrol, tetracyclines, warfarin, and phenytoin. From a practical perspective, it's important to eliminate unnecessary drugs and use the safest ones possible. During lactation, nearly all drugs can enter breast milk, especially those which are lipophilic. There's not a lot of reliable human data because, again, these studies in humans are difficult to do. We do know that most drugs are safe during lactation, but there are a few which you should be very cautious about, including amiodarone, antineoplastics, ergotamines, phenadione, chloramphenicol, tetracycline, and some psychotropics. From a clinical perspective, it's a good idea to dose women during lactation immediately after breastfeedings if possible, and that way we can minimize drug concentrations in milk at the next feeding. It's also important to avoid drugs that have a long half-life, and of course check valid clinical resources to see which drugs are least likely to have an effect on infants. The pediatric population is at increased risk of adverse drug effects, largely secondary to immature organ systems. Again, there's not a lot of drug information, and it's important to remember that in infants, drug effects may be more intense and or prolonged. So therefore, it's necessary to adjust drug dosages based on a number of factors. Body size alone may not be sufficient. There's increased sensitivity also due to the immature state of pharmacokinetic processes, and the blood-brain barrier may not be fully developed. It's important to consult the American Academy of Pediatrics, which always has updated guidelines. But there are a few drugs which you should remember that cause unusual toxicity in children, including ceftriaxone, and that's only in neonates, really, codeine, phenoxylate in children under 2 years of age, possibly fluoroquinolones, although the data is not very firm on that, prochlorperazine, and of course serotonin selective reuptake inhibitors. As you might expect, the elderly are a population which can be somewhat problematic in terms of safely providing pharmacotherapy to. There's a wide interindividual variation in pharmacokinetics, but we do know that the risk of adverse drug reactions is 7 times more common in the elderly, and it accounts for approximately 15 to 16% of hospital admissions and 50% of medication-related deaths. Most reactions are dose-related and not idiosyncratic, but some symptoms may be nonspecific, such as dizziness, cognitive impairment. There is a criteria called the Beers criteria, which provide guidelines regarding medication usage in the elderly. And some drugs that are good to avoid where possible include some of the first-generation antihistamines, such as diphenhydramine, antispasmodics, such as dicyclomine, tricyclics, such as imipramine, anticholinergic anti-Parkinson agents, such as benztropine, muscle relaxants, an example is methocarbamol, again, benzodiazepines, and antipsychotics. Also, nitrofurantoin, which is a urinary anti-infective, may be problematic in some elderly. Thanks for listening.